Hello, my name is Meredith Davenport. I've been an OBGYN for about 20 years now, initially in private practice, but in 2015 I joined OB Hospitalist Group as an OB Hospitalist. I very much believe that having an OB hospitalist helps elevate the standard of women's health care, and I'm very proud to have this be my profession. My initial program when I joined OBHG was a very busy program. We received lots of transports, we had our own service, and quite frankly, within the team, we probably had 2 to 3 life saves in any given week. So it was absolutely clear to me the benefit of an OB hospitalist in that scenario. Earlier this year, I transitioned to a new program that is closer to my home, that is a community hospital setting. And I wasn't entirely certain how this new role would correlate or what benefit having an OB hospitalist would be in this type of setting. So I have a life save story to share from this hospital to answer that question. So I was on shift one day and I received a phone call from a nurse. It was not a particularly busy day. And she said, there's a cord prolapse, and she told me which room. So as an OB hospitalist, I'm in the hospital at all times. I was on the unit, so I was literally in that room within seconds of receiving the phone call. So as I walk in the room, I actually realized that I know this patient. So I'm going to do a little sidebar here. But I met this patient in this hospital a few weeks previous. It was her 4th pregnancy. She'd had 1 term pregnancy, 1 preterm pregnancy, 1 miscarriage, and had 2 live children. Her prior preterm delivery had been around 32 weeks. She had presented to our OBED at 24 weeks with a complaint of bleeding that was actually unexplained. But during that process, I did check her cervix and found that she was a little bit more than 1 centimeter dilated and somewhat effaced, which is unusual at 24 weeks. So based on that information, we decided to go ahead and start steroids for fetal lung maturity. She received magnesium sulfate for neuroprotection. The patient's care was managed in the hospital by the primary OB, and she was subsequently discharged after a few days of being stable. And outpatient in the interim, she'd been managed with both maternal fetal medicine and the primary OB and had had no issues. So now I'm going to fast forward. As I'm walking in the room, she's now 30 weeks and 3 days. And she shared that in the morning she had gotten up and gone to the restroom and her water had broken. And then after that water breaking, she felt something between her legs. So she and her family put her in the car. They brought her to the hospital and she's now in our OBED. Literally as I'm arriving, because it was so fast, the nurse is just now getting heart tones on the fetal monitoring, and luckily they are initially normal. And so I start to wonder, how did the nurses know that this is a cord prolapse? And it's at this time that I pull back the sheets, and there's no kidding, a 1 foot loop of cord. So 6 inches out, 6 inches back, laying between the patient's legs on the bed. So I was like, okay, this is real. The nurses had already made contact with the primary OB. And interestingly enough, this OB has office space that's attached to the hospital. So if he is ready to walk out the door, he could be in the hospital within 2 to 3 minutes. So they had made contact with him. He was notified, and I was told he was on his way. So now seeing this cord, I turned to, again, fortunate to have 3 nurses now in the room. I asked one nurse to place an IV. The other was, again, working on getting heart tones to monitor, because it was a little bit difficult because there's a lot going on. And then the other nurse, I asked her to call the anesthesiologist to meet us in the back, and then also the NICU team so they could meet us in the operating room. So while that was going on, I went ahead and simultaneously I'm checking the patient, and I find that she's 3 centimeters dilated, and there's actually a fetal foot that is coming through the cervix. And each time the fetal foot is extending, it's actually compressing the cord, and so now I have more monitoring strip, and there's drops in the heart rate that are going down to the 60s for about 30 to 60 seconds. We weren't picking up contractions, so it may have been that, but we were having decelerations. So once the IV was inserted and we were seeing these dips in the heart rate, I made the decision that it was time to transfer to the operating room. So I elevated the foot as best I could because this is what I was correlating with the drops in the heart rate. I hopped on the bed and the nurses transported us to the operating room. By this time, the anesthesiologist was in the room, the scrub tech was also in the room opening, and the NICU team was arriving. So I gave everyone the report as the nurses in the room placed the Foley catheter and did the other just very rapid preparations. I informed the anesthesiologist that we needed to go under general anesthesia to expedite the delivery, and he was prepping his area to do so. Somewhere in the middle of all this, I was able to call again to the primary OB, but his voicemail was on, so I didn't actually get to talk to him directly. So I was proceeding as if I was going to manage this patient until the baby was out. So now the nurses are just about ready with preparations. I asked a nurse to elevate because we were continuing to have those big dips in the heart rate. So we changed places while I scrubbed very quickly. As I was scrubbing in the room, the primary OB walks in. I update him on the status. He agrees with the plan. He assumes the role of the primary surgeon, and then I shift over and am now going to assist him. So the patient very quickly was put under general anesthesia. Shortly thereafter, we began the C-section, and even faster after that, the baby was born. One of the sweetest sounds was that baby crying in the OR. The APGARs were 8 and 9. This baby did really well, despite being delivered at 30 weeks. And so I have my answer. I feel like in this setting of a community hospital, there's actually less likely to have a physician around. Most of them are in their offices, which are off-site. After hours, they're trying to maintain a work-life balance so they can continue to practice. So having an OB hospitalist in a hospital like this, it helps make sure that there's someone always there for patients, because emergencies can happen when you're least expecting it. And that's it. That's my life save story.